Hello. Hello, can you hear me?
We can hear you.
Okay. So, I am presenting the first case of today's workshop. She is a 45-year-old female, known case of hypertension. She had an episode of pancreatitis 10 months back after an ERCP that was done due to a CBD stricture. Since then, she has abdominal pain on and off with nausea and vomiting. Her CT scan showed a pancreatic duct that is prominent of 2.5 mm and gallbladder is normal with no evidence of a stone or mass. Her MRCP showed dilated pancreatic duct with irregular outline, no filling defect was seen, and reduced size noted in the body and tail of pancreas secondary to chronic pancreatitis. Her recent ERCP that is done on 6th of April shows distal half of the CBD is strictured. A stent was placed. They have given an impression of CBD stricture secondary to chronic pancreatitis or a duodenal growth. Her CA19-9 levels are 2.47. So we are now proceeding with the EUS.
In the PD. Where was the stricture exactly?
In the distal half of the CBD.
Distal half of.
Fatty score है, छोटी neck है, right? So what you can do is slightly hyperextend. इसका नहीं है. So neutral position में you stay away from the patient, and that's your neutral scope position, right? Now, as you go in, you get resistance. Why you get resistance? Because that is where your tongue is touching the hard palate. ठीक हो गया? At this point, your big wheel towards you. ठीक हो गया? And you push the scope forward. At this point, you will feel a give way. So step one is big wheel down and push the scope forward. And you give way, आपको feel. The give way का मतलब ये you now in the oropharynx. At this point, two things should have happened. Why? So step number one, your left hand should come here and your big wheel start to relax. जो आपने नीचे किया था ना, वो relax हो जाएगा. What is it? What does this mean? This means जब मैं oropharynx में गया हूँ, तो मेरे लेफ्ट पे पेशेंट का लेफ्ट पेरिफॉर्म फोसा है जो मैंने जिससे इंक्यूबेट करना है. तो बेसिकली, और आपको मैं इसलिए बाहर दिखा रहा हूँ कि ये पोजीशन थी जिस पे हम गए थे. अब हम ओरोफेरिंक्स में पड़े हुए हैं और ये पेशेंट का लेफ्ट पेरिफॉर्म फोसा यहाँ पे, राइट? सो द वे आई डू इट, आई विल रिलैक्स दिस and I've just lift my left hand from neutral to here and I've pushed forward and the scope will go in. ठीक हो गया? Let's try that now. Guys, can you hear me?
Yes.
So you've heard the case. So what we want to look at is the distal bile duct because there was a stricture, and we therefore want to assess if there's anything in the pancreas when we're in the distal bile duct, or may even be the duodenum.
Farooq, in a situation like this, do you generally start in the usual place and then eventually get to your target area, or do you go to your target area first and
no,
then
so
complete your exam?
I have always start from my usual place.
Okay.
Just the usual maneuvers. Unless I know there is a big lymph node or a big mass that I need, I would still go and start my usual place to get it helps actually. You get a lot of information from still your station 1, which is GOJ. If it's a pancreatic duct dilated, is there still there's intrahepatic, extrahepatic duct problems, and especially with the strictures, it allows me to see the hilum now. So I think it's very useful whether there is there or not, right? Okay. And the trainer contract, this is how to intubate with EUS scope, and station 1 showing the guiding structures A, aorta, and B, pancreatic duct. Okay, above वापस आओ. So let's come back to the heart. I know you've done that. Come back. So come back at 30. Okay. And so you see the heart there, right? Okay, now you're happy with heart structures? Or do you want me to talk you through it? You've got. Okay, that's fine. So the bigger ball, as you see, इसको वापस लेके आओ. So that's it. So the bigger ball that you see, where's the cursor here, guys? Yeah. So that's your left atrium, right? Now, if you slightly anti-clockwise, so counter-clockwise is this. So if you relax your shoulder ever so slightly, you will see that the left ventricle starts to come under the, and this is the valve. And left ventricle, that's, you go slightly anti-clockwise for me more, please. And as you pull, no, you go slightly easy. And you can see the, at this point, the left ventricle will go into the aorta there. Okay? Left atrium, left ventricle, aorta going out. Okay? Now, so this is just, जब आपने ये देख लिया, so now you will proceed a touch further. So, हाँ बिल्कुल. So bend आ रहा है इसमें, so hold the scope, your scope, yeah. Very slight and gentle push. We're going forward. Stop. जब हार्ट खत्म हो गया, तो हमें already ये पता लग चुका है कि we are now entering the territory which is the abdominal cavity, right? So end of the heart gives us certain amount of information that we've actually progressed further, becoming the end of the thoracic cavity, and we're about to start the. क्योंकि हमें ये पता है कि end of the heart actually sits on the diaphragm. Yes, would you agree that? Right? Okay, good. So already अब मुझे ये पता है कि मैं enter हो रहा हूँ. So the next structure जो मेरा first landmark है, looking at the interior of, हम interior देख रहे हैं ना patient को, right? Is what? So GOJ में अगर मैं पहुंचता हूँ, esophagus में बैठा हुआ हूँ, scope patient के anterior को देख रहा है, तो मेरे और patient के esophagus के दरमियान क्या structure आएगा?
Diaphragm and then the liver.
Liver, of course, right? So you know that your first landmark would be liver. Let's just see. Okay?
Yeah.
So all you have to do is literally, so when you see that the border of the heart is coming, you really need at that point 3 to 4 centimeter push without any torque in the neutral position, and all you're waiting for is the first guiding structures come on the screen. Okay? Go for it now. अच्छा, अब हमने ये बात पहले कर चुके हैं कि जब हमें liver नज़र आ गया, so our right hand at this point is become useless. ठीक हो गया क्योंकि हमें liver नज़र आ गया. And what are we now going to do? We will only support, if anything, with the right hand, and the left hand, which is now at the neutral position, should start to come up. क्योंकि हमें ये पता है कि अगर liver patient के anterior है, तो pancreas patient के posterior पड़ा हुआ है. It's behind it. So therefore, अब मुझे कोई एक ऐसा maneuver करना है कि looking from the anterior, I need to look at the posterior. In EUS scope, what allows for us to look from the interior of the patient to posterior is your left hand goes to the clockwise torque, right? Okay.
So it's a 90 degree or what?
So, okay, so when you've seen the liver, the first maneuver which should start to happen is that your left hand start the clockwise torque. And we know that the next stop, ये train journey जो हम कर रहे हैं, इसका next stop जो है वो aorta है, जो हमारा first guiding structure. But before we go to aorta, there's a mid, एक छोटा सा station आएगा जो हमें ये reassure कराएगा कि हमारा plane is still in which is hepatic and IVC.
Okay.
ठीक है? So that means कि हमने scope हमारा push नहीं हो गया, scope हमारा pull नहीं हो गया, our plane of reaching is at the same level. So जो mid junction एक छोटा सा station जो आ गया, that is actually your IVC. ये reassure कराएगा the plane, and all you do, you just then keep going further until you land on the aorta. Okay? You do it. Okay, so we know our plane is right because हमने अपना mid station meet कर लिया.
So that is IVC.
Yeah, that's it. So this is the hepatic vein, and you can actually see the IVC. You can actually see the heart pressure on. Okay, so at this point we know our plane is right. Well, all you need to do, थोड़ा सा पीछे आप खड़े हो जाओ ना, तो this will be easy for you, and give space to your left arm as well. And now you just keep going, as if by magic. You just keep going, and you should have aorta come in front of you. You're at the right plane क्योंकि हमने रास्ते में IVC को देख लिया. Keep going. That's it. Okay. Now, अब हमें ये पता है कि aorta जो है, that's actually going like a pendulum. We don't want that. Aorta को हमने बच्चे को slide देनी है कि वो ऊपर से नीचे आ जाए. ऐसा ये it's a sliding. So therefore, what you now need to do, you need to do something कि आपका aorta जो है वो trajectory बनाएगा ये, okay? So we've lost the aorta because we've gone more clockwise. So if keep no, so start relax, 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 relax. So when you say relax, that means your clockwise talk start to come anti-clockwise. Okay? So let's go a bit anti-clockwise. Okay, so we're coming at 30, we've pulled the scope back a bit. So push karen scope ko thoda sa. Okay, so it went, now go back. Yeah, so we go back. No, no, you need to hold, so just supporting. Okay, so there was the aorta there. Wapas aa jao. Okay, there we are. So it's in the round position. How do we want the aorta? We want it in the sliding, right? Always remember, बच्चे को slide दिलवानी नहीं चलानी. Remember? So there it is. So at this point, all you need to do is just so look at the position that's changed in your case. So you still come back a bit. Give room to left hand because right and थोड़ा सा भी आप करोगे so then you will see. Go to the left a bit. And you push. Okay, so we've pulled the scope back because we're seeing the heart. So therefore, हमें scope को push करना है. ठीक हो गया? Lever, right? Okay. What should happen at this stage? You go. Okay, that's fine. So let's do that. So start to go clockwise. But you इसको support करना. You don't have to talk from the right hand anywhere. Okay, beautiful. At this stage, keeping aorta in the middle, you push in and show me the celiac takeoff. So we've gone forward. So come back, slide, easy movements, slow. So in EUS, the movements are really in centimeters, a really small movement. Okay. So now you got the aorta there. So pushing forward, keeping aorta. So let your brain learn from your hand tips. That's the beautiful position as to where I'm going to get. So push through very slowly, millimeter by millimeter, keeping. अब ये बच्चे की starting position, remember? Yeah. So right. So push very gently, millimeter by millimeter, keeping aorta at the focus, millimeter by millimeter. Yeah. Keep going. I'm very happy for you to go. Achha, are you getting resistant at this stage? Okay. So trainees in the audience, it's very natural to have some resistance to your right hand as you push the scope. Why? Because हमें पता है कि अब हम GOJ पे पहुंच रहे हैं. You start to see diaphragm coming up there. This is where you get, so जो लोग ERCP करते हैं audience में, you know at this point, because हमें पता है कि जो GOJ है, the cardia, it takes slightly left turn. इस वक्त हम उसके ऊपर हैं, therefore हमें resistance feel हो रहा because we're going in the wrong direction. We know we have to go slightly left curve. So at this point, the usual maneuver is, ERCP में भी हम लोगों को पता है कि हमारा left hand left पे जाता है because we need to go through the cardia, which takes a left, slightly left curve. We then in the stomach, and then we take our ERCP scope here to look at the pylorus and we push through. Everyone agrees? And this is exactly what we need to do here. So your left hand in EUS, it starts to relax as you get resistance in the right hand. However, हमें पता है एक और चीज़ का कि इस अगर हम left जाएंगे, so we might lose aorta position. So to counteract that, your big wheels start to come towards you a little because then you kiss the mucosa at all times. So you use your big wheel to keep against the mucosa and you then relax your left hand to go through GOJ. And let's just do that now. So keeping aorta in the picture, you push gently. using your right wheel to go down, थोड़ा सा left जाओ तो आपका aorta जो है वो center में, keep it to the right now, yep, keep pushing, that's okay, it happens, that's all right. So what happens if you go anti-clockwise, see, right? So this is your EUS repeat, remember that? Okay, keep going, you're doing fine. Keeping aorta in the picture. So at this point your brain should learn, do I go right, do I go left, a small movement, and at this point your fingertips needs to have a connection with your brain. This is hand-eye dexterity, right? So when we teach in this is what it, and this is exactly what, when you do 4 or 5 times, your brain with your fingertips will learn the image and the hand movements to go through. But you're doing absolutely brilliant. Okay, keeping aorta in the focus there. That's okay. That happens. Yeah. So keep going. Keep pushing. Oh, that's okay. This happens.
Give, just easy giving.
Doesn't matter. Don't worry.
Sorry, this is can you increase like the depth so that
You want to increase the depth?
yeah, so yeah.
Okay. So the idea is to keep aorta in the, okay, brilliant. So we've come back.
This is just like falling down.
That's okay. You want me to show you?
Yeah.
Right.
So where I'm going wrong, so which thing?
Right. Okay, that's fine. So you got to the heart,
Yeah.
liver,
Yeah.
IVC, aorta there.
Yes.
जब आपने aorta देख लिया, so you start to sliding में.
Yeah. So
All I'm doing is my left hand hasn't moved yet,
yeah.
so you start to see the diaphragm there, right?
Yes.
And at this stage,
Okay.
my big wheel. डायफ्राम नजर आया था, आपने देखा मेरा हैंड यहाँ से लेफ्ट पे चला गया थोड़ा सा और मेरा बिग व्हील डाउन हो गया, राइट? एंड वेरी जेंटली आई एम डूइंग नथिंग, मेरा लेफ्ट हैंड मूव भी नहीं कर रहा. नाउ आई एम एट द जियोजे, सो लुक आई एम गॉन इवन मोर लेफ्ट. डिड यू सी माय लेफ्ट हैंड गॉन इवन लेफ्ट? और वो दैट्स एट द टॉप यू गॉट द सीलियक टेक ऑफ. और सीलियक के नीचे क्या है? अच्छा चलो अब आप इस तरह करो, यू टेल द ऑडियंस in this plane, where is the diaphragm, where is the celiac, and where is the SMA?
Okay. So this is aorta.
Well, no, use the cursor.
Yeah.
Use the cursor, Umu.
Yeah. So
Where is the
this is
diaphragm?
aorta.
Yeah.
The diaphragm.
Yeah.
This is the diaphragmatic structure, right?
जी ठीक हो गया.
Yes. This is as celiac trunk,
ठीक है.
and SMA should be here.
बिल्कुल ठीक है.
Okay.
अच्छा, so for the audience, just as you are here, जब आपने celiac take off देख लिया, so as we were discussing yesterday, the next maneuver, your scope goes down 2 to 3 centimeter more, and the wheel जो मैंने अपनी तरफ किया था towards you will relax, big wheel away from you, so all, and the pancreatic body will fall right in front of, and so let's just see that. So 2 to 3 centimeter scope push, and I've relaxed the wheel, right? And there you have the pancreatic body right in front. This is the pancreas in front of you now, right? Okay, अब आप आ जाओ.
So what I was doing, I was just moving clockwise. Yes.
ओके, सो रिमेंबर हमने अभी ये बात किया ना कि चूंकि ERCP में हमारे पास कार्डियक लेफ्ट पे जाता है पेशेंट के, तो जो आपका लेफ्ट हैंड है उसको स्लाइटली जो आपने क्लॉकवाइज टॉक किया होता है, यू हैव टू ईज इट अ लिटिल टू कीप इट इन द फोकस. ओके, एंड लेट्स डू दैट. सॉरी, आई विल टेक दिस वे. This is liver. We've got the pattern in IVC. We start to go to the right. आगे चलेंगे. Right. So now start clockwise. We're not pushing the scope in. We're not pushing the scope out. Our right hand at this stage is only supporting the scope as we go from the left to the right. Okay, so you're at the aorta now. We're quite happy कि हम aorta पे पहुंच गए. No, so aorta is still to the clockwise. There it is. Okay. अब आपने यहाँ पे, what do you think you need to do next? Okay, push. All you do is slide push. Beautiful image. आपका लेफ्ट हैंड बिल्कुल मूव नहीं किया ना? क्यों नहीं किया? अभी तो हमने बात किया कि उसको करना होगा मूव, राइट? Okay, so we've come back. That's fine. Very, very small movements on. Okay. Nicely done. That's okay. Keep going. Keep going. जी मेरा नाम फारूक खान. Thank you. So yes, so this is so trainees in the audience. There is a term for this in the trainee. This is called cognitive overload. So when we see someone doing the procedure and explaining all this, things look very easy. As soon as we hold the scope, all our cognitive, all the intelligence from the brain, it comes to the hand, and we want to do it because we don't quite understand as to how we implicate that right into the knowledge. This is called cognitive overload. अच्छा, अगर आप endoscopy educationist से बात करें, so the maximum overload that you get in endoscopy is during EUS. Why? Because you're doing two skills. You've got radiology skills and you've got endoscopy skills that you want to combine. OGD has got the least cognitive overload, followed by colonoscopy, followed by ERCP, and EUS being the most. Because you've got two skills over here. So the way to deal with cognitive overload is don't worry about it, and you come back to your guiding structure one. Okay. So the next, and now let's talk about the top of the scope and the scope movement which will get you from point A to point B. All right, good. So we know कि हमें aorta ढूंढने में तो problem नहीं हो रहा है, right? Okay.
Now to maintain that position is a problem.
Which is fine, and you won't be the first trainee in the world जिसको aorta से GOJ में गुजरने में issue हो रहा है, and we'll spend as much time as it needs, because what we want your brain to learn on this course, कि what maneuver that my fingertips did, so the brain nerves have engaged. And so therefore, when you do it next time, it becomes unconscious incompetence, right? So from there you move to unconscious competence, right? So you don't even know, but you're just doing it. So that becomes your reflex, right? So in the training paradigm, from conscious incompetence, you move to unconscious competence, right? Okay, go.
So, as a trainer, at what stage do you feel that it's time to consider moving on, as opposed to continuing with the same process?
So I think as a trainer, it's where I feel we intervene when I know that the next step, not that he's not doing, but the next step he does not know. When I know that he knows the step and is not able to do, then we go through the maneuvers that will take from point A to point B. And even if that is not happening, then at that point we'll take the scope, we'll show them how to do it, we give the scope back, and if this isn't working for them, the second time, at that point, I'll take the scope and we'll move to the next step.
Yeah, and I guess so that I don't think we have necessarily made it as I don't know, stepwise in the US yet. I know there have been a couple of studies out of Colorado that they've talked about
So
reaching
afterwards we
competency. But
you're still in the liver. जो pancreas आप देख रहे हो, ये from the left side देख रहे हो.
the-
जी जी, I'm
I
listening.
guess the question becomes, at what point does one say, okay, in the interest of the patient, one has to move towards completing the procedure as opposed
yes,
to?
so as I said, that once if the trainee has what you just need to go through the steps of it, and the steps from one point to the other is not just that he knows, is actually can he actually link that, can the trainee link that information to his hand. So information from brain is what does he know about it, this is the cognitive knowledge, and can he link that to his hand and return back to the brain. And I think the problem that we're having here is the knowledge is there, this knowledge of the scope is there, but problem from the hand coming to the brain, that's where we're having the problem, which is a very, very common problem. This is the first time, by the way, OM is doing the EUS.
Sure. So the other thing is, as you know, like more than one maneuver can work in a situation. Here, what I tend to do is have my trainees look at the endoscopic view and actually basically go anti-clockwise with their left hand and see the gastric
so
folds.
you got the diaphragm, you got that. Okay, happy with that? So you've got the diaphragm there, and you've got celiac, and you've got the SMA. Happy with that now? अब आपके brain ने ये learn कर लेना, your fingertips intelligence will now tell you what maneuver, so slightly left, and you will see that time. So you've already seen this 3 times without your brain and this is the barrier I wanted to break. You with me?
Yeah.
Now that you've learned, even if I go quiet and I say, can you show me the celiac, you will be very happy and showing me again, right?
Yes.
So by spending time focusing on it, this was missing. The knowledge to the hand and the hand skill coming back to the brain, which is now there. Let's just see if you can do it. G. मुझसे कुछ पूछना? That's fine. So after this, what I will do, I'll take the scope and we'll finish the procedure.
And by the way, I'm not sort of at all
Yeah,
implying that you should. I mean, I was just
no. That's
because
fine.
the methodology is different from honestly what I do. That's why
Yeah,
I was curious.
I know it gets. I'm very, very training focused. So at some point, it does become frustrating. I can see in the audience you probably.
Oh no, not at all. It's
Yeah.
really for my education, our education, how things, how you practice your.
See? So now he's already shown me 6 times, because जो missing था ना audience में जो early trainees हैं उनके लिए भी ये याद करना ज़रूरी है. So from conscious incompetence, Om has now moved to unconscious competence, because इसकी nerves ने hand tips की ये learn कर लिया है कि क्या small maneuvers मुझे करने होंगे कि ये मेरे. So this is the 7th time he's showing me that, and that was the whole idea of the trainer contract of this station was this. Okay, happy with that now?
Yeah.
Achha, I know we've achieved. I just want you to do another step, if you can, for me, please. Can you? So this is your tip of the scope. I want the pancreas to come here. Okay? So therefore, no. You don't anything until we talk about. We haven't discussed that station yet. So the next stage of this is 2 to 3 centimeter of the scope push. And the big wheel जो आपकी तरफ आया था आपने उसको away करना, and the pancreas will come under you, and let's do that now. Okay, so 2 to 3, keeping celiac into focus, and now the big wheel will go away from you. So push 2 to 3 centimeters inside the patient, keeping that into view. Even if you can't do that, that's fine. That wasn't the trainee contract, but it will give you enough confidence that next time I should be able to land onto the pancreas.
Clockwise or should I?
So no, up.
This,
So you
yeah,
know-
didn't push the scope, yeah.
Yeah. So you're missing the pancreas. Make it okay. That's fine. I'll take it.
Okay.
That's okay.
Thank you.
No, no, that's all right. Oh, we got suction. That's fine. I've got.
Dr. Anand, what was he saying about the training?
Huh?
So what was he supposed to teach us? Like he was saying something, Dr. Arang.
Mustafa, there's a question from Om. You were saying something about endoscopic view.
Oh, I was just saying that, you know, in these situations, an approach I take or recommend to the trainee is look, when you get stuck on that G junction, as you were saying, go counterclockwise with your left hand and endoscopically visualize the gastric mucosa and then advance slightly and then go clockwise again. So similar to what we do in ERCP, but using endoscopic visualization. That's what I was saying.
Thank you. So there's actually, if you look at the where's the cursor gone now? So far, we know this duct is dilated, we're in the body of it, and there is some periductal inflammation, and the pancreas does, I have to say, it rather looks atrophic.
Yes.
I'm at 4 centimeter. Let me just go to 5 and see what happens then. Yeah, even if I go close, look at the splenic vein. It's just right next to my probe, so there's not much pancreas left. There is there. Okay, so let me just follow this through to the tail. So clockwise, 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 clockwise. Yeah, so your pancreas pretty much finishes there. Not much there. Duct is a bit dilated in the body. I would like to. And can you see the hyperechoic edges of the ducts there? So this is all pointing towards chronic pancreatitis. There is some. Let me just freeze it.
Like you were saying yesterday, that the chronic pancreatic duct will be like chalk.
Chalk. Did you see that? So those white signs there. So at this point, I want the duct to go into the head, and as you can see, it's थोड़ी सी light आप लोग कम कर दोगे कमरे में? Right. So far what we know pancreatic duct is dilated, there are hyperechoic walls, there is some hypoechoic pancreas with some stranding, and I'm going to go to the bulb now. And she was stented yesterday, is that right? On 6th, sorry, I beg your pardon, it was a couple of weeks ago.
I'm not, I think from what I remember, she had attempted ERCP, but it wasn't successful.
Oh, I see. So she hasn't actually got a stent in there. Is that right?
You know what? That's what I remember of the story.
Okay. All right.
Yeah.
All right. Okay. All right.
And I don't remember her age. Do you remember that?
45, Mustafa.
Okay, thanks.
I think she's 45. So there is, can you see that mass in the head?
Yeah.
So let me just see. And there's lymph node, Mustafa, there?
Yes.
Come along as
Yeah.
well. Yeah, let me see if I can see the extra pancreatic bile duct, and let's go to the hilum and follow it down.
D2 or you will
No, I've come back. I've come back to the entrance. So Can you guys see the endoscopic image?
Yes.
Yeah, not terribly clean, is it?
No.
There is some difficulty, as you can see, getting into D1 there. Was there any stones in the gallbladder on the CT? I can't. Well, what's this? That one there. No, not terribly impressed about the stone, really.
This one, right? This maybe.
Yeah. It's in the wall, I think, rather than actually within the lumen of the gallbladder, this thing. I'm not sure this is what I would like to call stone. Really? Yeah. Sorry. And it's not really budging either, so I'm not sure this is a stone really.
No, I think her LFTs are normal, if I'm not mistaken.
Okay.
We should double check on that.
Yeah.
The main issue was the pancreatic duct stricture.
Well, my feeling is she's got a mass, Mustafa, I think.
Yeah, and what? Is that a large lymph node, do you think, or?
Yeah. Let me just see. She has had a stent put in, did somebody said.
Oh yeah, we can see it. Yeah.
Yeah, that's a stent. Can you see that?
Yep.
Yeah.
We're just pointing it out to the audience here.
Yeah,
you can see the air refluxing up the duct.
Yeah.
So when you have these two parallel lines.
So the bile duct is actually, if you
That's
look at it, it's
bile
completely collapsed as it goes to the intrapancreatic course, and then there is this mass around.
Okay, yeah, but maybe because of the stent it's left.
Because of the?
Stent
Yes.
less in CBD.
Can you just freeze
Yeah.
it? Could you just freeze it for a second and just highlight the stent? Just show them, how it appears on EUS, if you don't mind.
Yeah, no. If I can go back to it.
Yeah.
There it is.
Exactly.
And now we go to cursor. So
These
this
are
is the stent.
yeah.
That's the direction it's following, right? Yeah. Okay.
Thank you.
That's okay. So this is the stent, guys, right? It's gone this way.
Yes.
Yeah. When did she have an ERCP? I think there is some degree of obstruction there, really.
I think that was reported that there may be some duodenal obstruction.
Yeah. There is some, I'm afraid, and that's the mass there, which is completely actually engulfing around the artery as well here. And so that, I think, is the bile duct which is completely filled. That's the hepatic artery there. I'm actually inclined to biopsy this mass really, because I don't think I'll be pushing into D2, guys. You can see that I can't. I'm in the bulb, and you can see the whole D2 closes on me. So I have no real intentions to really push it through to the poor girl, and I think I'll probably. मुझे needle दे दें, please.
Needle दो.
So would you do
Rima.
like CRE dilatation of the
Needle
D2
ma'am.
and then you can pass this because they have
No, not with EUS really, because the idea of EUS is to look at the pancreatic head. So the question from Om is, at this point, would you like to stretch the D2 and then go for the sake of? So for ERCP, you do that because आप लोगों ने obstruction को release करना होता है. So you do need to go there. For EUS, I don't do that really, because I was asked to look at the pancreatic head. I have looked at it. Is there a mass? The answer is yes. What do I do next? I take biopsies. Do I really need to do the stretch dilatation and be in the D2? The answer is no. I can do that sitting in either in the antrum or in the D1, and I'll take biopsies and I'll call it today.
Yeah. So there is a slightly slimmer linear by Olympus, which is 11 millimeters. It used to be called the P140.
Oh yeah.
And one can use it, but your point is totally valid that if you can get to the area of interest and sample it with your current scope, you don't have to push it and especially dilate, especially the duodenum.
Needle size.
FNB है रिक आपके पास?
FMB.
अगर एक्वायर है तो वो दे दें, अगर नहीं है तो दे दें. Thank you.
So, just looking at it, do you think that there could be potentially a component of chronic pancreatitis, or do you think this is purely malignancy? Like, how, just by appearance, what's your overall suspicion?
So this is where, if you don't mind and allow me to say, I use elastography.
Sure. No, we're here to learn, so that's why I'm asking the question, like, how, either way you would sample it, right?
Actually, I tell you, the answer is yes. So we have a 28 bedded pancreatic ward, believe it or not. So the surgeons that have, so हमारे इतने cases हैं जो chronic pancreatitis versus malignancy.
Right.
But we have to answer. So actually, putting elastography helps me कि अगर मैं report करता हूँ कि मैंने biopsy कर दिया है, लेकिन elastography पे it was all green, and I couldn't really see any much more to it, then when it goes back to MDT, it helps them to decide कि अगर फारूक की biopsy भी negative है, उसका impression भी elastography का है, so we can actually keep this patient under follow-up and repeat the CT in 2 months rather than going mad about repeating another FNB, doing another EUS, or trying to do spyglass to see if we can see any pancreas. Are you with me? So it does help us in so many ways. Our patient doesn't have to go through so many loops. Purely because it's just 28 bedded HPB ward. You have all the chronic pancreatitis lying there.
Yes.
When they start to get jaundice, then the question comes, well, where do we go now?
Sure. No, from our perspective, even as faculty, we're here to learn and see what practices other people have and take those back.
And we'll always have times
subtle differences,
of
right?
Course,
yeah.
Of course,
yeah.
of course.
So is this a 25 gauge or a 22?
So it's a 22 gauge FNA. So this is FNB.
Sure.
I wasn't quite sure what's happening, and as it happened, one of our friends messaging on WhatsApp, and I was like, where is that beep coming from? It's okay. No, they're very helpful. We can't run these courses without their help, to be honest. So because I'm in the interim, you're really not getting the full picture of the needle for the sake of the trainees. You might just see some now as I managed to get It's ever so slightly difficult. So trainees, early training, I think it's really important to put a Doppler before you do it. Although this vessel here, I'm not really too pushed even if I go through this. That's okay, it's a very small one. But you should really put the Doppler on. At the early, sorry, yes, ko band kar dein, please. At the early stages of your, where's the cursor? And
Yeah, it only adds like 5 seconds, so I think it's worth doing every.
Yeah, true, agree. It adds a lot more to your safety, so do it please.
Yeah.
Make it routine. Let me just see the needle. There it is. Okay. हाँ जी निकाल लें please.
पूरा निकाल दूं?
हाँ जी निकाल लें.
Yes. Okay.
So you passed one and twice.
So 1, and then change it a bit, 2, 3, 4, 7. No. So Om is asking, would you keep, once you've done the biopsy, will you keep the Doppler there to see if the bleeding has happened? The answer is no.
Yes, thanks.
अगर सेल्स आ गए ना उनसे पूछना तो मेरा ख्याल है उनसे कहना TIP कर लें, टच टेक्निक भी आप लोग प्लीज कर लेना. थैंक यू. Trainees in the audience, do you want to ask any questions whilst we're waiting? Use this time by all means. You've got trainers in the room.
We've been, we've been answering some
Oh,
questions.
you've been discussing. Good, thank
but,
you.
Just the role of, I know that there's going to be a talk on sampling, but the role of the stylet, especially with these biopsy needles.
So, okay, so is somebody answering from there?
No, again, I'm interested in your opinion.
So, okay, I was just measuring the mass for the report. Oh, actually, guys, one of the things that we need, before I forget, one of the things we need to do today is take the trainees to do the report. And so reporting EUS is ever so slightly different from any other reports that you do. Mustafa, I'll come back to your question. I'll just tell them the stepwise report writing.
Sure.
So it really, really helps. इसकी फोटो कहाँ से लेते हैं रिक? आपको पता है इसका? How do you save it this image?
सेव हो गया आज एक दूसरे.
अब हो गया बस सेव? अच्छा जी, ठीक हो गया. So it's decent mass, it's 4.5 to 3.5. अच्छा जब हम EUS की report करते हैं, so I think the first heading or the first part of it is the background. So background में I'll encourage trainees to write exactly जो आपको case present हुआ है ना, just in 1 or 2 lines. You don't have to write huge about it. So 45-year-old, recurrent pancreatitis and a CBD stricture. CT showed no mass for EUS assessment. End of. Nothing more than what's needed. हाँ वो देख लें. And then you would see second part of your EUS report is you write radial or linear EUS. I think it's believe करो कि अभी भी out in the world not many people know what's the difference between the, even if it's your gastro colleagues जिनके लिए आप report लिख के भेज रहे हो ना, they don't quite know whether it's what's the difference between the radial or the linear. So I think it's useful if you write linear EUS and then you start what you have seen. Don't write straight on what your impression is. It really is helpful. आपको भी when you need to go back to that report a year later or somebody asks you, it's important what you have seen. The second part of the report is what you have done. And the third part of that report writing under linear EUS is that what do you think it is? And then the last part of the report after is your impression and forward plan. So there are 3 parts of EUS. One is the background, middle is about the EUS, that's got 3 components. Component number 1, what you've seen. Component number 2, what you have done. And component number 3, what you think it is. And then you get to the last or the conclusion part where you say, okay, that's how I think. We will wait for the biopsy if that's what it is, and for MDT discussion, or for ERCP for stenting because I think this is a mass, or ERCP for stone removal because this is what it is. Let's let sample. Is it enough? नहीं है? F and B में ना, sometimes we get enough samples, so we don't really have to go back in again. अच्छा लेंगे एक कर लेते हैं. अच्छा, coming back to your question, do I take stylet off or not? Acquire needle में, I don't know what other people experiences. I have to sharpen the needle by taking the stylet inside of the scope. So I do, before I puncture it, I just take a stylet inside about few centimeters, and then I puncture, and then I start. Once I've taken the stylet out, I really don't go back in with the stylet because you've in there, you've made it. Unless the nurse has put one back in, but I don't normally say कि नहीं यार इसके बगैर आपने मुझे देना नहीं. So I sharpen without the stylet. Once I'm in the lesion, stylet is out, and the next time when I go many times, I just go without the stylet completely. No stylet at all. Let me just see the needle now. अब stylet को थोड़ा सा बाहर निकाल देते हैं. Thank you. That's helpful. Okay. अब आप stylet निकाल लो please. मुझे कैकों की आवाज आ रही है कमरे में से. Don't you think I can't hear you?
नहीं हम जी, we're discussing our old stories.
Yeah, that's exactly what I mean. So I'm just trying to take it from the periphery as me and Mustafa discussed it yesterday.
Our old stories of our young age, so don't worry about that. You don't want to hear those.
Okay. Certainly not live. चल.
So they're making slides on these?
जी जी. और वो खालिद भाई वाली टच टेक्निक भी उनको मैंने कहा है कि वो करें प्लीज.
Maybe we'll come over and look at that for a second.
I think we're done. निकाल लूँ उसको,
मैं पूछ ले रहा हूँ.
आप देख लो प्लीज.
I will watch Farooq while.
Got the good sample? Okay, that's fine.
Can I give you the G-junction वाला station करता हुआ हूँ.
आप if you want to, you do, but I think you might get no please by all means. उसका D2 structure है तो बस आप उसको push मत करना.
I'm coming back. No, I'm just looking at the same station.
Oh, you are fine. Happy with that. Of course, happy with that. So Om wants to spend some more time on withdrawal at station 1, and I have no serious objection to it. But do let me know from the powers to be if we're running late. We're more than happy. We've actually quite finished. We've achieved the contract. चलिए ये माइक उतार दें प्लीज. Yeah. यार कितनी खूबसूरत लैंडिंग है. Yes, you can see that the difference you've made to it. Diaphragm, celiac. Beautiful. Very nice. SMA. Thank you. Already come there. थोड़ा सा पुश करना आपने 2 सेंटीमीटर और देख को रिलैक्स करना. इसका बहुत छोटा फ्रेम है. डोंट एक्सपेक्ट कि मुझे इतना बड़ा चाहिए. यू नो दैट शी इज नॉट.
No, it's okay.
Beautiful. So you found the SMS straight away, didn't you?